So as mentioned already, I'm a medical doctor. So when a patient comes to a doctor, he wants basically to have treatment. And before we can start treatment, and this is true not only for rare diseases, this is for any disease, for infectious diseases, common diseases, and so on, you have to have a diagnosis. So good medical care starts with the right diagnosis. And this is really to communicate with each other, also to health authorities, also to better define the impact of the disease in the family, even if we have no treatment available, as commonly still it is a situation for rare diseases. But then again, it's a big relief for the patients, for parents to connect with other families in the internet and say, well, that's exactly the same problem I have. How do you handle it? So it's extremely important to have a clear disease and not just symptoms to give into the web-based internet and to find partners for this. Now, the point is, and Sarasa mentioned it, for rare diseases, which is defined in the European Commission with one among 2,000 persons, we have, if you may say so, the advantage that roughly 80% are estimated to be caused by monogenic diseases, which brings genetics into the forefront of the diagnosis or of technology actually to find the disease. And the really problem is that most of the patients we have in our lab are rather in the groups of micro-rare or nano-rare diseases, so extremely rare among the world, and that means we have to share data as quickly as possible, because when we find one potential cause in one patient which has not been discovered or described before, we cannot prove that this condition is really the cause for the disease in this patient or in the family. We cannot say something about recurrence risk and so on. So we have to share data and we have to get organized in networks. Most of you probably have already involved or applied the whole exome sequencing in routine testing. However, and this is true for all studies across the world, it's far less than 50% of the patients what we solved applying whole exome sequencing, and what means in terms of numbers that worldwide more than 150 million patients would remain unsolved, even applying the most sophisticated whole exome sequencing for each one of them. So there is definitely a strong medical need to implement whole genome sequencing. In our lab, we implemented whole genome sequencing like 5 years ago for all indications, and you know that the genome is basically much better covered than instead of exome enrichment. However, we have to admit that even with whole genome sequencing, the word is somehow misleading. It is not the complete genome, but it's rather like 93%. There are major gaps with the short-read genomes, what we have to face. There are these large repetitive sequences, the repeat expansions, the pseudogenes, and so on. And with these new technologies, what we are talking about today, the long-read sequencing technology, we can even have a first insight, if not complete, but a first one into the genome modification. So moving from, if we move from the exome to the genome, it may be even wise to move to the long-read genome in the first instance. Why is that? Because, as I mentioned before, there are these strong gaps in coverage here already with the small deletions and insertions. The copy number variations are also for the short-read genome far from being complete. Structural variants are even less detected. The repeat expansions, the short ones, we do detect easily also with the short-read genome. However, there are so many large-scale repeat expansions where we cannot cover and not identify the motive underlying for this. And as I mentioned before, pseudogenes or more or less is really in particularly bioinformatic problem or challenge for the short-read genomes as well. And we have a couple of genes which are need to be zengered afterwards to really have a completion of the genetic diagnosis, even if we perform short-read sequencing in the first instance. Now, this brings up the potential of the long-read sequencing, where we have the nearly complete genomes and nearly complete small indents, that we have the haplotyping or phasing of them. Structural variants are pretty well defined by these repeat expansions. I think all of them, what we have today, at least medical relevant repeat expansions, we sequence through with the long-read genomes. And of course, we can cover also the pseudogenes. Of course, we can apply this technology also in the RNA. And I just want to show you the point here at the bottom right, that we more or less have all-in-one technology covering the genome, the partial of the epigenome, and do the parental phasing, what may be important for instance, for recessive diseases, in that one seeing that both variants you identify affect both alleles. When I say here, I'll just go one back, complete genome, you can see that still the brackets, because even with a normal long-read genome, that is still not the complete genome. So we could move into the really complete genome. What I think there were a couple of talks today and yesterday on the T2T, telomere to telomere sequencing, and what we have achieved using ONT technology only to really generate the first T sequence. And Kaspar was just gave a talk on this before this meeting. Now, with all this potential, we still have to say we are very early in the implementing it in the health technology. It's still not really defined, despite all the success, as I mentioned, what are the most important indication groups for patients where we should apply it first, where is the major or the best advantage compared to the short-read genome. And so we have to combine the data in the clinical setting. We mentioned the epigenetic part of it. So that's also, in our opinion, very much in the early steps. And so that brought us together in saying, let's form a network. And the network already expanded to more than 100 participants from 15 countries. And it's called the European Long-Read Innovation Network. And this is not on special structural things or on biology, or so it's rather on bringing the long-read technology into diagnostics. What are the limitations and what are we facing? So we formed the networks, and it is our aim really to bring the largest long-read genomic sequence reference data for human patients. So it's not on biology in terms of evolution of apes or plants, or so it's really on human and patients, and explores whether or not or how feasible it is to have long-read sequencing as a first-line diagnostics, brings together also the clinical experts together. And of course, it stands not on its own. It's tightly interacting with the EDERA network coordinated by Hans Gressner, which is initiative of the European Commission on rare diseases, and on the 1 million genomes projects on the genomes of Europe, which is coordinated by Andre Uterlinden to generate reference data. But basically, ELRIN is on patients and on clinical genomics, and also to help the people setting up the bioinformatics. And this is mainly done by Stefan Ossowski, who is the head of bioinformatics in our institute. And as I mentioned before, Kaspar and Jakob are the major people, but there are 25 bioinformaticians working on this. So we have a structure within ELRIN. That's the coordination center in Tübingen. We have monthly Zoom meetings. We have wet lab and bioinformatic working groups. We have Google documents where we share all the protocols and documentations, where we also mention what patients have we solved, or which means unsolved. We have a Slack channel for communication, and we had a first face-to-face meeting. All these things are already done and established, and we are aiming towards a bioinformatic workshop on the unsolved ONT long-read sequencing data, most likely in October this year. So that's basically the structure we gave us. We have discussion points which are not solely to the ELRIN consortium, which is true for all the European networks, so data access federated, but how can we get access? And we will not develop a new structure on its own. We will use and follow the GOE guidelines and access things. So I think that's wise to not create another new structure somehow, so that is clearly decided. The working groups I mentioned before, how strong, how quickly should they interact, what are the teaching parts, where should the teaching be done, how often do we offer it, what is the demand. So that is a challenge, of course. We would like to aim to reach the first, or to publish, get the data together, analyze the first 1,000 long-read genomes from ONT this year. There's still a discussion, should we focus on certain disease cohorts, or should we just use widely and not only in rare diseases but also on common diseases or infectious diseases. So there's this ongoing discussion. What we have, we will publish data and conclusions, what we have from all our interaction. And we are still think that there's a strong need also on reference data. So we are not there yet. As you know, we all these points, and particularly to the epigenome, is a major point. And as I mentioned before, even the normal long-read sequencing is not a complete T2T sequencing. So we are working on the T2T reference sets. The epigenome, I will not go into details, but the technology is really exciting, how we can look at it. It's exciting not only in terms of regions, but also in terms of genes, to dissect the parental origin also of the methylation. So that's a fantastic tool. However, as I mentioned before, our databases are not complete. I go back one more slide. So we don't really have an epigenome reference data set yet. So the world is working on that. We are working on the epigenome of identical twins to set some standards and so on. So it is a challenge, but will be also openly provided to the community. And also there are still some structural gaps, and we just had in the previous session a talk on the variants on chromosome 16, clearly showing that the current reference genome, the HG38, has gaps and has limitations. Here in a case of a TAR syndrome, where we have 2 de novo deletions in one Q21, and this was true for short and long-read sequencing. However, the T2T CHM13 reference genome really points at that this was indeed just 1 deletion and not 2. So I think we have to move into the T2T sequencing, and this was what I really can say. It's not magic actually to do so. So there are some gaps in doing it. Of course, you need a bit more flow cells to provide. You need a different kit for DNA isolation, but otherwise it's really straightforward. We can do this, and I think because we have like 1,000 or 2,000 genes which are not covered by the normal long-read sequencing, and of these are 99 predicted to have an open reading frame, we have to move forward, and we have to define what would be probably even the best to go for the T2T sequencing in diagnostic. I'm really talking about in diagnostic. So we have to set standards now. And very lucky with ONT, we have a partner in terms of technology, which drives the technology further and makes it also in terms of pricing, financing, really acceptable to move into this direction. And so that's a challenge what we will do, but we have to go and define what are the advantages of T2T sequencing in diagnostics. The first 2 genomes you may download from our homepage, so they are freely accessible, and the homepage is the ELRIN homepage, where we are sequencing right now 20 different persons from across the world, from different ethnic background. Of course, we are working together with the Pan-Genome Reference Consortium. Of course, this is also part of the genomes of Europe. Of course, we are working together with EDERA and so on. But I think we have to move, and we can move forward faster. Faster is because we are working really together as colleagues, as friends, knowing each other for many, many years. So we had a wonderful kick-off meeting in April, just last month, with many talks, and got, I think, a great momentum. We know that a lot of technology is required for this, and ONT is helping from one side also to get it across the different labs distributed, and also supporting the startup of all of this. We are also, as a consortium, helping in setting up bioinformatics or giving advice on the preparation of all of this. If someone wants to join ELRIN who is not a member of ELRIN yet, you may go to our Slack channel, or you may directly contact Beate, who is the coordinator of the ELRIN consortium. With this, I would just point to the ELRIN homepage, and for the ones who would like to download the T2T, you may also access via ELRIN homepage the T2T genomes. And here I stop now with my presentation, and thank you all for your patience.